What's going on, guys? I know everybody hates the car videos, but this is what I've got. It's Sunday. I want to start the conversation. I'm about to go into Home Depot and I figured let's chat. Let's talk about the difference between what's a covered service and what's not a covered service. Why this is so important, not just to you, to your business, but to the profession at large. You know, I think there's just so many misconceptions around this whole conversation that we need to flesh this out. Now, I'm not the self-proclaimed expert on this. You know, I'm not the one that's going to be making these decisions. I'm doing my best to try to understand the guidelines, try to understand the regulations, just like you. Because I'm faced with these challenges every single day. Yes, my Medicare beneficiary would love to have Medicare pay for the service. Yes, it would be easy for me as a business owner to just let Medicare foot the bill. But ethically, morally, personally, I just don't feel like I can blindly turn an eye to what may or may not be covered without having rational references, resources behind my decision making. So in this series of videos, I'm going to start with easy and go to complex. We're going to do one case a day probably. And let's see if we can flesh this out. I don't think the conversation on Facebook is very helpful because there's no perspective, there's no context. We need an actual patient. We need to look at real situations. So while I'm changing the details about the individual to protect HIPAA privacy, these are real situations, okay? So let's start with what I would consider a relatively simple, straightforward case. Let's take a gentleman, we'll give him the name John. So John had been a patient in my clinic previous. John, just for context, John has Parkinson's. He's been diagnosed, but John is fully independent, lives independent with his wife. He drives, he dresses himself, bathes himself, takes care of personal hygiene and grooming. John manages his finance. He does everything he needs to do in the community. John loves golf. John's a retired executive. He goes out golfing 3 to 4 times a week. Now, John was a patient of mine. He was discharged, let's say, 6 months ago. So I'm familiar with the case, right? I'm familiar with John, with his history, with his context, his support system, his medical complexities. Let's say John is overweight. John would be considered obese based on BMI. John is diabetic. John's hypertensive. He has some health complexities, right? But everything is stable week to week, month to month. Nothing is really changing. He's on a solid regimen of medications, sees his family doc on a regular basis. John is living his life. And so now, you know, here's the case. So John gets referred to me for physical therapy because of neck pain. John woke up 3 weeks ago, his neck hurt. The day before, he was hanging decorations, getting ready for Halloween, and he is convinced that he lifted something, did something, strained a muscle, and now his neck hurts. He's still playing golf, but he's not playing as well as he normally does because the pain interferes. The pain tends to go away while he's golfing, but the pain's an issue before and after. And if he's going to play a full round of golf with his buddies, he's going to pay the price that night, the next morning, with increased neck pain. So it's a nuisance problem, right? It's not limiting his function. He can still do things. He's just doing things with pain. So he's referred to physical therapy. He's been to my clinic. He's been to the hospital outpatient-based clinic. He chooses to come to me because I can get him in within 24 hours. And we have a rapport. We have a history. So John comes in for the initial evaluation. I determine there's no red flags. There's no significant, like, neurologic conditions. His Parkinson's hasn't changed. His diabetes, hypertension, none of that stuff has really changed. It's not a complexity that's going to affect his ability to do what needs to be done. He's got some sore muscles. He's out of shape. He's been deconditioned to where I saw him previously. And I believe that's it. Like, he just needs to get in shape. He needs to sleep better. He needs to eat better. He needs to improve his body's ability to recover. The normal muscle strain that you or I would be dealing with isn't getting better. He's kind of stuck in this chronic cycle of pain, inflammation, swelling, etc. So I give John a home exercise program. I'm like, look, John, here's the great news. range of motion, strength, all of these things are within normal range based on you, based on your previous findings. I understand you have pain. I understand you did some physical exertion and you attribute the pain to that. But regardless of what caused the condition, there are no red flags. There is no reason this will not get better. This is not an injury as much as it is a healing problem. If it was an injury, it would have recovered in the first 24 to 48 hours. This is 3 weeks in. You're just not healing. Your body's not able to heal. Now, certainly we know from Parkinson's and your past case history, if you slept better, right? You have some difficulty sleeping. You're waking up multiple times a night. We know interrupted sleep will negatively influence blood sugar levels. We know you're diabetic already. We know you're hypertensive. You've got these other medical issues. They too will influence how quickly you can heal. So what you need to do, you have a couple options. Option number one, do these 3 exercises, do them at home the way I prescribe them multiple times in a day. This will change the chemistry locally where the tissue injury may have occurred. And within 3 to 4 weeks, you should be back to pain-free. If not, come back in, we'll do another assessment and we'll update the programming. That's option number one. In that case, everything was paid for by Medicare. Medicare paid for the eval, Medicare paid for the plan of care, the goals, everything, and it paid for me to show John 3 or 4 things to do. John cognitively is intact. He had no problem demonstrating what I showed him, and I kept it simple enough that he doesn't need a follow-up session. Okay, option number one, fully covered by Medicare. Option number two, John, I know that you like the soft tissue work. I know that if I rub your neck and your shoulder, it's gonna feel better. It's not gonna fix the problem, but it's gonna give you temporary relief. You can go play golf pain-free after I work on it for that day. The next day the symptoms will come back. That's where the home exercise program is required. If you want me to do those things, this is the cost. It's $50 a unit. I think you only need a 15-minute unit of soft tissue and manual therapy. You can do your exercises when you leave the clinic. You can come in before your round of golf. I'm happy to do it. Or you can come in after and we can do a recovery treatment. But this is not a covered service. This is fully paid by you, the client, because it's not medically necessary. It's only something you can have if you want it. You don't have to have it. Option number two. Option number three, we go through a full golf performance program. We look at your swing. We look at, your warm-up. We look at everything that you're doing on the golf course. Maybe there are some things we can do golf-specific that get you ready, and maybe there's something going on. Maybe it wasn't hanging the decorations 3 weeks ago. Maybe something in your stroke has changed. Maybe something in your, whatever. I'm not a golfer, but you get the idea. That too is not a covered service. So maybe I do a 15-minute manual treatment that's self-pay, not medically necessary, followed by a 30-minute golf performance program, right? All self-pay, $80, $100, $150, whatever you're charging, doesn't matter. Maybe you're a TPI certified golf performance coach who's also a physical therapist. These might be $250 sessions. You have the right to provide that, but you have to understand that just because you have the knowledge, the skill set, the ability to do it, doesn't mean Medicare should pay for that, right? And like I said, keep in mind, this is an easy case. This is a simple case. This should be very black and white. I have a hard time with anybody looking at this scenario and say, well, Tony, you absolutely should be doing manual therapy on his neck because it relieves his pain. Medicare isn't paying for pain relief. Medicare is paying for return to function. It's medically necessary. Pain relief is not medically necessary. If John got dressed, bathed himself, cared for himself, personal grooming, feeding, bathing, all of that stuff, taking care of finances, and he's still playing golf, he's just playing golf with pain, that is not a Medicare service based on the guidelines that I have read, that I've shared, that we've all talked about. That doesn't mean I can't provide the service. That doesn't mean the service doesn't require an elevated, advanced understanding of human physiology and kinesiology and biomechanics and all of that stuff. It's not discounting what we know and do. It's simply saying, look, this payer isn't, like, the policy isn't designed to pay for this service, right? But it's not a personal attack on what physical therapy is. It's simply an understanding of, these are the guidelines, this is what's medically necessary, this is what I can provide. You're welcome to buy it if you want. You're welcome to forego it if you don't want it. But from a medical perspective, there's no reason John's not going to get better on his own. There's no reason John needs the skills of a therapist to do these 3 or 4 exercises on his own, right? So let's start with that case. You tell me, based on what I've shared, if I'm wrong. Now, you might do the same assessment on the same patient. You might be like, no way is John safe to do these exercises independently. No way is he, you know, these 4 exercises that I want to prescribe are adequate for him to achieve his goals. That's fine. That's a professional disagreement. That's you and I talking peer to peer. That has nothing to do with the third party payer, right? But when I'm a professional and I have those 2 letters after my name, and I've determined that John doesn't really need more than what I've provided, that's my decision. John can go down the street. He can go to the hospital clinic. He can find a therapist there who's, I don't want to say it, but who's compelled to bill more units, who's compelled to prescribe John a 12-visit treatment plan of care. That's fine. That's their decision. You know, for me, this is my decision. As a professional, as an independent therapist, this is what's medically covered, medically necessary. This is what's beneficial, but not medically necessary. John, you make the decision. You know, and if you want what I have, you have to pay for it. It's not something that's covered by Medicare. Medicare does not pay for everything. And I'm not going to sacrifice, I'm not going to put golf performance under the guise of medically necessary just so John comes to more sessions. I'm not going to put some sports massage soft tissue work that's not medically necessary under the guise of required manual therapy simply because I want John to get more sessions. I want Medicare to pay me more money. Like that is the ethical dilemma that I think each of us need to figure out for ourselves. But we can't make these decisions based on hearsay. We can't make these decisions based on opinion, emotion, based on what we've always heard. We have to make these decisions based on established policy published by Medicare guidelines or whoever the third-party payer is. So again, I'm not saying I'm right. I'm not saying you have to listen to me. I'm not saying you have to do anything that I say, but I think we have to have this conversation. We have to open this up to internal dialogue, and then hopefully together we can come up with some sort of rationale. You know, maybe I'm too far on one end of the spectrum. Maybe there's other therapists too far on the other end of the spectrum, and you fall somewhere in between. But for now, day 1 is in the books. Case 1 is in the books. Tomorrow we'll talk about a little more of a complex case. Maybe somebody who's got some more medical complexities, more comorbidities, other things that are going on. And, you know, maybe it's not quite so easy to say, oh, this person doesn't need the skills of a therapist. This person should be able to do it on their own. Let me know what you guys think. Put it in the comments. I'll catch you on the next video.